Often misdiagnosed, fibromyalgia can result in severe pain that may interfere with the ability to perform even the simplest tasks. Dr. Robin Dore is a rheumatologist at St. Joseph's Hospital right here in Orange, and she's an expert in treating this syndrome. Robin, thanks for coming.
Thanks for having me, Larry. I appreciate it.
You know, as a cardiologist, this is a complex disease and a confusing disease to me because I'm looking for chest pain all the time, and I'm trying to figure out, is it your heart? Is it muscular? Is it from the lungs? And I don't always know. So usually for me, I can say it's not the heart, but I don't know what it is. But what is fibromyalgia exactly? What do the words mean, and what is it?
Well, fibromyalgia, myalgia means pain, and fibro just means in the connective tissue. So patients who have this syndrome hurt all over. And if you look at the definition, it's chronic, widespread pain. So pain all over your body, but there are actually 18 predefined tender points where in order for someone to be diagnosed with fibromyalgia, they need to have at least 11 out of 18 of these tender points.
So with arthritis, it's going to be where?
In the joints.
It's going to be in the joint.
So arthritis would be, let's say, in the joints of the hands, the shoulders, the hips, the knees, and fibromyalgia is, in your patient's case, in the chest wall. It can be in the back, it can be in the calves, it can be along the side of the hips, it can cause headaches, but it's not in the joint. There is no swelling with joints in fibromyalgia.
So if a patient comes in with joint pain, can there be an overlap? Can you have arthritis and fibromyalgia, or is that common or no?
Unfortunately, it's very common, and then making the diagnosis is even more difficult. Some people with lupus or rheumatoid arthritis that are autoimmune diseases have what we call secondary fibromyalgia, where they have pain in the muscles as well as the joints. Hopefully, if we treat the lupus or the rheumatoid arthritis, then the fibromyalgia might get better, but sometimes not. So then you try to cut down on their rheumatoid or lupus medicines and treat them more with the fibromyalgia medicine.
Which are different again. And you're going to tell us about that. So let me ask you about these points. Are these like trigger points where you touch it and they have to be tender, or is it just they say I have an ache here and I have an ache here in these areas, or do you have to precipitate the pain by touching it?
You need to precipitate the pain by touching it. And classically, these patients are hypersensitive to everything. They can be hypersensitive to light, to touch, to smell. I have a patient who brings in her own lamp because the fluorescent light bothers her eyes. That many can only wear cotton clothing because the synthetic fabrics bother them. But so they are, or smells, or different foods, or tastes. And it's really a hypersensitivity syndrome where things easily bother them. And that's one reason it's so difficult to treat them, is because the medicines that we use bother them as well.
Oh, you're really stuck. So is it something at the nerve endings, or is it more the central brain perceives the pain in a different way, or is it really the nerve endings? In other words, if you do a block, will you have less pain? Or no?
It's really coming from imbalance of chemicals in the brain.
Really?
We know of at least 3 chemicals and probably more: serotonin, norepinephrine, and substance P, and these are pain modulators. People don't have enough of norepinephrine and serotonin. These are chemicals that help people feel less pain, and they don't have enough of this in fibromyalgia. And substance P, that stands for pain, these patients have too much of it.
I see. So it's an imbalance of those chemicals.
That's right. And so women who have fibromyalgia will have pelvic pain. They'll have a hysterectomy. They'll have their uterus taken out. The pain's still there because it's coming from the brain, not from the pelvis. So it's very difficult to treat.
So when you have this, so if you put somebody on, like for arthritis, you'll treat them with what?
An anti-inflammatory, pain medicine.
And that does not work for this?
This does not work at all. We have to use medicines that affect the pain chemicals in the brain. The problem when you do that is that some of those medicines cause sedation and others cause agitation, the people to be too hyper. So it's very individual from patient to patient.
Now, I understand there's new medicines out for this, or just released medicines in the past few years. What are they, and how do they work?
In the olden days, in 1980, when this was first described, we called it fibrositis for inflammation and used the anti-inflammatories. They did nothing. Then as time went on, we used muscle relaxants, and they help relax the muscles, but they didn't do anything for the chemicals in the brain. And then we started using Neurontin, a seizure medicine, which worked pretty well. And then the first approved medicine came out, something called Lyrica, which is an anti-seizure medicine, but it also helps pain perception.
I see.
And then we have two others.
What are the others?
Cymbalta is one that was initially approved for depression, and then a brand new one, Savella, which is the first medicine on the market only for fibromyalgia, not for depression and not for seizures.
So if one group of patients work with, say, Cymbalta, the other one work better with Lyrica, is there any clues based on their exam or anything that say, hey, this is the drug I should use? Or
it really comes down to the individual patient tolerance, but also certain patient types. Lyrica is associated with weight gain, so if I have a heavy-set fibromyalgia patient, I will not use Lyrica. Cymbalta or Savella are associated with weight loss, so if I have a patient that's overweight with fibromyalgia, I'll tend to go with one of those. But in some patients, we actually give them Lyrica at night that causes some sleep, good sleep, and then we'll give them the Savella or the Cymbalta in the morning to sort of wake them up. Because people who have fibromyalgia, besides that widespread pain, have terrible fatigue. So for my female patients who've been pregnant, I say it's like being 14 months pregnant. You can just not get up and move.
wow. So does this happen premenopausal, postmenopausal? Are there hormone-related issues with this? What's the story with that?
It must be hormone-related because when we look at women and men, it's typically 9 women to 1 man. Typically begins either around the time of the girl's first menstrual period or with a pregnancy, but then tends to get better. One of the good things about menopause is it tends to get better at menopause.
If you've had it earlier on.
If you've had it earlier on.
Okay.
And what we do know is that like most chronic illnesses, stress makes it worse. So whether we're talking about your patient who has true cardiac chest pain, my patient with rheumatoid arthritis or fibromyalgia, the stress actually lowers those chemicals in the brain that deal with pain, and so the stress can make it worse. But that's not specific for fibromyalgia.
Is there anything like non-pharmaceutical, like coenzyme Q10, fish oil, magnesium, physical therapy, acupuncture that works for these kind of people?
The best sort of thing is actually exercise. And again, we're really lucky right here in Orange. We have the Rehab Institute of Orange County just down the street from St. Joseph's.
Right?
And they actually have a water fibromyalgia exercise program called Fibrosize. And it is the warm water given by an instructor trained by the Arthritis Foundation that actually leads the exercise program. So exercise, good sleep hygiene, not having a glass of wine or a cup of coffee right at bedtime. Some studies have shown that a combination product called Fibroplex that has malic acid and magnesium in it can be helpful, but the fish oils, the SAMe, the coenzyme Q10 really don't seem to make a difference.
And just, we're almost out of time, but there is no test for this, right? There is no blood test, there is no CT scan. It's your expertise.
It is. Now, certainly with these patients, they can have a borderline positive blood test for lupus and ANA and a really low SED rate, which means there's no inflammation, but it's really testing for those tender points.
SED rate meaning sedimentation rate that measures inflammation.
That's correct. Very low inflammation.
So if somebody has these diffuse aches and pains, they really should see perhaps an expert like you who can put it all together for them and try and figure it out?
I'd see the primary care doctor first and make certain, because what we look at, what else can cause this? Low thyroid can cause this. Just depression can cause this. But if you look at MRIs on patients who have stress and depression and fibromyalgia, there's a big difference there. But we're not going to do MRIs on patients to diagnose fibromyalgia. So because there's 4 million Americans with fibromyalgia, rheumatologists can't take care of them all. So we want primary care doctors look at all the things and then send them off to the rheumatologist.
Very good. And that's what they're going to do then.
All right, thank you.
Thanks so much for coming in. It was a great talk. I learned a lot.